Good afternoon. I would like to thank the organizers for the opportunity to present the work on this Congress. My name is Mario Habek. I come from University Hospital Center Zagreb in Croatia. And the topic of this talk is autonomic nervous system abnormalities may predict cardiovascular changes after initiation of siponimod in the treatment of secondary progressive multiple sclerosis. These are my disclosures. So siponimod has been associated with decrease in heart rate at treatment initiation and development of hypertension during the treatment. So the aim of this study was to identify whether autonomic nervous system function or dysfunction identified prior treatment initiation can predict siponimod related decrease in heart rate after starting siponimod in people with secondary progressive multiple sclerosis. For this study, we enrolled 26 people who suffer from secondary progressive multiple sclerosis, and we performed the following autonomic nervous system testing protocol. We started with 10 minutes supine resting position, following with Valsalva maneuver, deep breathing test, 10-minute tilt-up table test, followed by 5 minutes supine resting period, then ingestion of siponimod, and then 3 hours supine resting period. We performed heart rate variability analysis, and we investigated them as a possible predictors of decrease in heart rate after started siponimod. So this is the baseline characteristic of our cohort. You can see that this is a typical cohort of active secondary progressive multiple sclerosis patients. The mean age was around 50 years. Majority were females. Median EDSS was 6, so they had a high disability and disease duration over 17 years. Around 40% of the cohort had active MRI in the previous year, and 42% had a relapse in the previous year. You can see previous disease-modifying therapy before starting siponimod, and on the right-hand side, you can see the results of the baseline autonomic nervous system testing with adrenergic and cardiovagal indices showing sympathetic or parasympathetic dysfunction in the studied cohort. So after treatment initiation with siponimod, we observed a drop in heart rate, which was statistically significant from 71 beats per minute to 66 in the 3-hour period after ingestion of siponimod, and we saw statistically significant increase in systolic blood pressure from 130 millimeters of mercury to 117, and elevation of diastolic blood pressure. However, this elevation of diastolic blood pressure was not statistically significant. We then wanted to see whether some of the observed autonomic parameters could predict this decrease in heart rate, and what we saw is in both univariate and multivariable logistic regression model that disease duration and standard deviation of NN intervals in the supine position, again prior to starting siponimod, was predictive of decrease in heart rate in the 3-hour period after ingestion of siponimod. We know that standard deviation of NN intervals is a marker of overall heart rate variability. However, short-term recordings like performed in this study are a majority consequence of parasympathetic nervous system function, indicating that parasympathetic nervous system function abnormalities may be indicative of decrease in heart rate after ingestion of siponimod. When we look at the results for the increase in systolic and diastolic blood pressure, we saw that normalized high-frequency power was negative predictor of increase in heart rate for increase in both systolic and diastolic blood pressure. However, only in univariable logistic regression. In multivariable logistic regression, we could not confirm this. This is probably due to small number of enrolled patients. However, we know that a low high-frequency power has already been associated with development of hypertension, so this may be indicative if we could include more patients and follow them for a longer period of time. So to conclude, treatment initiation with siponimod is associated with a drop in heart rate and elevation of blood pressure. Disease duration and standard deviation of NN intervals were identified as the predictors of decreasing heart rate, and we observed negative correlation between normalized high-frequency power and increase in systolic and diastolic blood pressure, however, only in univariable logistic regression model, and this needs to be confirmed in a larger cohort of patients over a longer period of time. And at the end, I would like to thank my collaborators who work with me on this project. Thank you.